March webinar. 9th March, there is a group.
Yeah, let me.
In your WhatsApp, there's a 9th March group.
Yeah.
You are live now.
Welcome everyone today to this very important webinar. And this is again being done in the Glaucoma Week, where in the Glaucoma Week, World Glaucoma Week, which is being observed from March 6th to March 12th. This is an interactive webinar on new advances and practices in glaucoma diagnosis and management. And I have with me my co-moderators, Professor Rajesh Sinha and Dr. J.S. Bhalla. And we have a galaxy of speakers today with us who actually do not need any introduction, who are glaucoma experts from various parts of the country, Dr. Rajesh Parikh, Dr. Ronnie George, and Dr. Ajit Hazari. So Dr. Rajesh Sinha is the Honorary Treasurer of All India Ophthalmological Society and is consultant at Cornea Cataract and Refractive Surgery Services, RP Center for Ophthalmic Sciences, New Delhi. And Dr. Jatinder Bhalla is the Secretary of Delhi Ophthalmological Society, and he's Senior Consultant at Deen Dayal Upadhyay Hospital at New Delhi. We are going to be doing the first talk, which is going to be given by Dr. Ronnie George. And he's going to be talking about field vision testing advances, CETA Faster and 24-2C. Dr. Ronnie actually does not need introduction at all. We've had him just yesterday on, again, our Glaucoma Initiative Week public webinar. He has been awarded the Thomas Gold Medal for the best outgoing postgraduate in ophthalmology by Christian Medical College, Vellore. He's also received the Thiru C.K. Kumaraswamy Gold Medal by Dr. MGR Medical University for MS Ophthalmology. He's received multiple awards for his publications and research work on glaucoma and has trained over 60 glaucoma fellows and has been a guide for PhD, DNB, and MPhil programs. He has published over 125 peer-reviewed indexed articles, 1 book and 12 book chapters, and delivered over 250 lectures at various conferences. And he's the past Associate Advisory Board member for the World Glaucoma Association and is the past Secretary of the Glaucoma Society of India. He currently serves on the Education Committee of the World Glaucoma Association, the Editorial Board of Journal of Glaucoma, and is the Section Editor for Glaucoma for the Indian Journal of Ophthalmology. Dr. Ronnie George currently is the Director of Glaucoma Services, Medical Research Foundation at Shankar Nethralaya, Chennai, and we welcome him. And he's going to be talking about field vision testing advances, CETA Faster and 24-2C. So over to Dr. Ronnie George.
Thank you, ma'am, for the kind invitation. I hope my screen is visible.
Yeah.
So I'll be talking to you on 2 recent advances in visual field testing. We are all familiar with the Humphrey Field Analyzer. It's been with us for a long time. And CETA, which we started using from 1997, has undergone few changes over the years. The hardware has undergone few changes over the years. And the CETA Faster came out about 5 years back. And the CETA 24-2C came out about 4 years ago. The advantage of the Faster is that it tests much rapidly in about 2 minutes or less. And the advantage of the 24-2C is that there is more information in the central visual field. I'll talk a little bit later about mixed CETA GP and the other advantages that these have. Now, the big advantage about CETA Faster is that you can test on an average in about 2 minutes or less without a compromise of the visual field test results. So this graph over here basically shows you how the testing times have changed over time. So CETA standard still takes on an average about 5 to 7.5 minutes for the test. CETA Fast about 3 to 5. CETA Faster 24-2C, even though it tests additional points, still manages to test in about 2.5 to 4.5 minutes. And CETA Faster 24-2 in between 2 and 3.5 minutes. It uses the same CETA algorithm and the same normative database as CETA Fast, and it's clinically equivalent. The way it manages to do this is it removes a lot of dead time between the tests. That is times at which you are actually not testing the patient. It also doesn't formally test the blind spot or false negatives, but focuses on the gaze monitor and false positives for test quality monitoring. So this was the first study which came out, which spoke about this. And it spoke about a few things. One, it said that it saves considerable time. Two, that there were small differences between CETA Faster and CETA Standard, but not greater than what was previously shown between CETA Fast and CETA Standard. And there's a small increase in high false positives on CETA Faster versus CETA Fast. So what they showed is that there were no statistically significant differences in the mean estimates of visual field index mean deviation at test points among the three test variations. What is important from a glaucoma point of view is that the test retest variability for both CETA Standard and CETA Fast was similar. And this is important because for progression, we need to make sure that the test retest variability is similar in different field protocols. It's also recommended that we test at least 3 times a year in the first 2 years that a patient is tested, because that makes it easier for us to pick up progression. So this graph shows you the mean test times. And what's important here is, in general, as the disease becomes more severe, that is, as your VFI values become less, you're going to take longer to do the test. And this you can see consistently in the black dots on top, which is the CETA Standard, in the red rings, which is CETA Fast, and in the blue rings, which is CETA Faster. You can see that across the entire gamut of disease, CETA Faster is actually significantly faster than both CETA Fast and CETA Standard. And that is important when you have busy clinics and you can do the test more rapidly. The other important thing when you look at progression is interpreting the test retest variability curve. What this basically means is, at different threshold values, when you test a point repeatedly, you can have slight differences in the threshold values detected. And this is called the test retest variability. In general, the test retest variability is much more for lower threshold values as compared to the higher threshold values. The graph actually looks like this. When the defect progression occurs, in normal vision, you have low variability. With early defects, again, you have low variability. So multiple times you test, the thresholds are very similar. With moderate defects, the variability increases. With advanced defects, the variability is much higher. So you might have a variation of at least around 6 decibels between a point, between two testings of a point, which is around 12 decibels at the first testing. With very severe defects, the variability again reduces. So CETA Faster has similar variability compared to CETA Fast at even low thresholds. So these are the 3 graphs there. CETA Faster is the blue, CETA Standard is the black, and CETA Fast is the red. And you can see that they all follow a similar pattern with no big differences. All the 95% confidence limits overlap. So the test threshold variability is very similar for the 3 testing standards. In our own unpublished data of about 100 patients, we found that false positives and false negatives are very similar between the two. They were not statistically significantly different. A little higher maybe in CETA Faster, but did not approach significance. In terms of duration, CETA Faster was half the duration of CETA Standard, and this was statistically significant. In terms of VFI and mean deviation, we found that CETA Faster and CETA Standard actually had almost exactly similar visual field indices. Mean deviation was marginally different, but this is probably not clinically significant. PSD was actually similar in both devices, in both testing strategies. I will now walk you through a few examples. And this is somebody who has a near normal visual field. And you can see that with CETA Standard, the time was about 6 minutes, and with CETA Faster, it was 1.56 minutes. Both were reliable fields if you look at the gaze tracking worm at the bottom. And you can also see that the VFI is 99% and 100% between the two, really no difference. This is another person with maybe early defects in the inferior field here. You're seeing somewhat similar defects on CETA Faster, not exactly the same, but somewhat similar. But the VFI values are very similar for both at 98%, and the test duration is again less than half the time taken on the CETA Standard. So this is somebody with slightly more classical visual field defects, and what you're seeing over here is superior arcuate with some central defects. This is denser on the CETA faster, which you're seeing on the right. Again, BFI numbers are very similar at 93% in both. And the test duration over here too is about 2.5 minutes compared to 5.6 minutes for the CETA standard. So much faster, and defects are fairly similar. In this patient here, you're seeing a defect which is an inferior arcuate defect on CETA standard. You're seeing a few defects in the same area in the CETA faster, but they're not as dense as that you're seeing on the CETA standard. BFI values are similar in both groups. So this is important to remember that you may not see the exact same defect on both tests all the time. You do see it most of the time, but occasionally you will not see the same thing. This is somebody with, again, fairly large superior arcuate defect. Very similar defects on both times. BFI is almost the same, 82 and 83%, and test duration is 6.18 minutes on the CETA standard and about 3.5 minutes on the CETA faster. So as the disease becomes a little bit more severe, sometimes testing times on the faster go up a little bit more. So this is somebody again with a much denser defect on CETA fast, on CETA standard, very similar defect pattern on CETA faster. BFI is a little bit different on both sides over here, 72% versus 85%. And so again, just to reiterate that you may not see the exact same defect pattern every single time, but most of the time you do. This is somebody with a fairly scattered defects, both in the superior and inferior hemifield. You see a similar pattern again on CETA faster, but not exactly the same. And here now you have somebody with a dense central and inferior defects on both CETA standard and CETA faster with very similar BFI values on both. This is somebody with a very dense defect, with very advanced damage, with a BFI of 14% on CETA standard and 15% on CETA faster. Again, the defects are very similar, whether you're looking at early, mild, moderate, or very severe disease. And the test duration here is 7.4 minutes for CETA standard and just 4 minutes for CETA faster. So one of the challenges with conventional testing with the 24-2 was that there were opportunities to increase the number of points that are tested in the central visual field. For example, with the 24-2 visual field, this blue cross shown on the right side.
Yeah, good evening.
Shows you the distribution of points that are tested by the 10-2. And if you have defects in the 24-2, you typically order a 10-2 and then you can see those defects more magnified. But in the second row, you can see that there are no defects on the 24-2, but if you do a 10-2 for the patient, you do see early defects there. And so there is information in the visual field in the central area which we are not capturing. And this was the reason that they consulted experts and decided to look to see whether they could actually add additional points in the 10-2, which were critical to detecting early visual field loss in the central area, which we would have missed otherwise. And based on the expert group consensus, they selected these 10 locations. So these 10 locations, unlike in the rest of the visual field, are not symmetric. They are locations which they were picked up because they were felt to be most likely to be to represent central damage. So you have 3 points in one quadrant, 2 points in the other quadrant, and 3 points in the lower and 2 points in the lower right quadrant. So these are the additional points that you're seeing on the 24-2C pattern. Keep in mind that these don't really address the 4 cardinal points next to fixation. So you cannot use it to look at the risk of split fixation, but otherwise this gives you information that you can capture quite easily. And when they assessed 24-2C versus conventional testing, they found that it actually is much better at flagging central points compared to otherwise. So in terms of the other parameters, it was very similar, but there was increased total deviation and pattern standard deviation of flagging of these central points in patients with who would otherwise have been missed. It also gives you the ability to look at mixed analysis where you can use both CETA standard, fast, faster, 24-2 or 30-2 when you're looking for progression. All of these can be used either in isolation or in combination. And this is one example which has been contributed by Dr. Murray Fingeret, and you can see that this is somebody with some damage centrally there. The OCT is somewhat abnormal. The 24-2 CETA standard shows no defects, but when you do the CETA 2 faster, you're seeing these central points which are showing defects. And this is where the big benefit of the test is, because you don't need to do a 10-2 on everybody. You can actually pick up the central defects with the 24-2 itself. And this is the other eye of the same patient, and you can see that those central defects are actually being detected early. So this is somebody whom we have been following up, and you can see the fairly dense central defects. The 10-2 shows significant damage there. When you do the 24-2 for this patient, you can see those central defects being picked up without a problem. This is the other eye of the same patient, and you can see here that the 24-2 shows that there are no central defects there, which is shown on both the 24-2C and the 24-2. So this is somebody who, based on the damage in the other eye, you would have considered doing a 10-2, but now you can avoid doing that. Here, this patient, this is basically a screenshot from Forum, and what you're seeing here is for a baseline, we're taking one test which has been done on the 24-2 and the other test which has been done on the 24-2C. So you can use a mix of tests to use as a baseline for progression analysis, and that's a big benefit there. This is somebody whom we are following up over time, and you can see that the baseline over here was 24-2C, and you can see that the progression analysis can be used just like you would use otherwise. This is someone who's had 24-2 here and 24-2 in the top and the bottom fields, and 24-2C in the central field. And you can again see that you can use these seamlessly to look for progression. So to conclude, CETA faster is much quicker and as accurate as CETA standard. It's backward compatible, which is really, really important from a glaucoma progression point of view. You do get additional central information with the 24-2C, which you might miss on just conventional 24-2 testing. And this is really a useful addition for visual field testing going forward. And it makes your life much easier because it's much quicker and you can do many more visual fields in the same amount of time. Thank you.
Thank you, Dr. Ronnie, and that was a wonderful presentation. And I just have one query before others can ask. I was just listening to your talk very, meticulously, and what I could figure out was that CETA faster appears to be better in terms of sensitivity and appears to be better in terms of its speed. So do you think 24-2 CETA standard is going to be obsolete with time?
No, there are certain compromises that are made when you go for speed. And that is that you assume certain things in the visual field. You may not actually map threshold as closely as you do with CETA standard. So those are compromises that you might do with the 24-2 faster. So it's not going to be obsolete. It's still going to be part of your armamentarium. But when you're having repeat visits for the patient, somebody who's an experienced perimetric patient, you can easily do a CETA 24-2 faster, and that makes life easier.
So can the two be compared?
Yes.
Okay.
Yes. So that's the reason I showed you the last few examples, because you can seamlessly use them for progression analysis. So rather than doing comparisons of the printouts, use the progression software and that information is there.
And one more question. Do you think that is it related to like a specific type like CETA faster or the CETA standard can be preferred in specific conditions, like depending upon the severity of glaucoma, maybe early subtle changes, as you showed that, some central points could be detected in faster but not detected in standard, or maybe severe cases
Yes.
Sake of knowledge, I would like to know.
So anybody with defects, with let's say a notch at either pole, is very likely to have central defects. So in those patients, doing a 24-2, you may want to do a 10-2 also, just to make sure you're not missing any central defects. So there you could easily do a 24-2C and quickly screen for central defects. So this suspect doing a 24-2C adds about half a minute to the testing. But you have ruled out that you're not missing any central points. So to my mind, you could use a CETA standard or a CETA faster on practically anybody. In somebody with very advanced damage where you want to map the central field a little bit more in detail, you may want to do a 24-2 CETA standard and a 10-2, both.
Okay.
I had a question. Would you say that the Sita faster you can possibly do in those patients who are not cooperative, or who can't do the Sita fast for a longer period of time, as compared to Sita faster, which finishes in shorter period of time?
Actually, that is a misapprehension that CETA fast and CETA faster are easier to do. Basically, because it assumes that, it's quicker because if you're used to doing perimetry, you're faster at it. So it reduces the gap between thresholds. So somebody who finds it difficult to do perimetry for the first time, doing standard is probably a better bet than doing either fast or faster. In fact, if you read the book which you have got if you registered for this meeting, the inventors of the device also state that clearly.
Okay.
So that means, Dr. Ronnie, if I may ask, so that means it is about 50% faster than the CETA standard. And as far as the parameters like visual field index, mean deviation, pattern standard deviation are concerned, they are also comparable. Would you recommend this and those group of patients who are already experienced enough to do the test? In those patients, we can really rely upon them that they'll be doing, and these are the patients where we'll like to save time. And that is one question. And secondly, as you said, where there's notch and we expect the central defect, we can combine 24-2 with 10-2.
Yes. So basically, you can definitely use it for follow-up patients because you can seamlessly use it for progression analysis. In patients with a notch, where you would anyway have been forced to do a 10-2, you can do a 24-2C because you will quickly screen them to see whether there are central defects. So definitely it's helpful in both those situations.
Right. Can I just ask one basic question? What exactly makes it faster?
Okay, there are two things that it does. One is it does not check for fixation losses. Otherwise, what it would do is it would shoot a stimulus at your blind spot and see whether if you saw it, it knew that it had moved. So those 14 times that it would test for fixation losses have been taken out of the equation. It instead relies on the gaze tracker. It also doesn't test false negative, where it would do everything but show you a stimulus. And if you're one of those happy clickers, you would just press the button. So those two formal tests go out of the picture. That saves you about 1.5 minutes. And then normally there is a certain gap between each test. So it's reduced that gap. So if you're quick, if you're alert, it will show you the stimulus that much sooner.
But then does it reduce the reliability? Because if it doesn't check the fixation loss, doesn't check the false negatives.
If you actually look at the gaze tracker on any of the printouts, the gaze tracker is a much more accurate way of monitoring fixation than the fixation losses, because fixation losses you check 14 times. The gaze tracker is on throughout.
So that was really nice. And so shall we move on to the next talk?
Yeah, I think the next talk is by Dr. Rajesh Parikh.
Yeah. So the next talk will be by Dr. Rajesh Parikh, and he'll be talking on OCT and its ever-advancing role in the treatment and management of glaucoma. Dr. Rajesh Parikh is the medical director of Shriji Eye Clinic and Palak's Glaucoma Care Center at Andheri, Mumbai, where we are going to have the next AIOC. Dr. Rajul won the Thomas Koshi Gold Medal in Ophthalmology for the best resident in MS. And after finishing his post-graduation, he joined Lund University, Sweden for his advanced fellowship. He is society editor for International Glaucoma Review and committee member of the World Glaucoma Association since January 2018. Maharashtra Ophthalmological Society bestowed him with the prestigious award for glaucoma pharmacotherapeutics for his research and contribution in glaucoma management. He has written chapters in 17 books and has 4 publications in peer-reviewed journals and 17 in non-peer-reviewed journals. He has been invited as a faculty in more than 150 state level, national level, and international level meetings in the last 10 years. Has held various positions, including treasurer, executive committee member in Glaucoma Society of India, His main areas of interest are glaucoma, neuro-ophthalmology, and uveitis. These are some of the points, but the fact is this, that he is a very renowned and a very established glaucoma surgeon whom every patient wants to show. So let's have Dr. Rajesh Parikh for his talk.
Thanks, Dr. Rajesh. Yeah. So can you see my slides?
Yeah.
Okay. So I'll be talking about OCT in glaucoma management. So these are the topics. I'll try to cover some of the topics in next 20 minutes. Why imaging? What is the logic, like perimetry logic? Perimetry, we are used to it. So I'll just compare with the perimetry. How to read the serious printout, though now people are using OCT for a long time. What are the World Glaucoma Association consensus? Little bit about the progression and its implication. And forum, the structure function correlation, I will not go in detail because the next speaker is going to talk in great detail about the structure function correlation. So we know that glaucoma is a progressive optic neuropathy. It's basically the changes in the optic disc and nerve fiber layer changes with correlating visual field, where IOP is the causal risk factor. So and if you look the literature, the optic disc and RNFL changes usually happens before the perimetry, at least on white and white perimetry defects picks up. So there are some of the studies have shown that 20 to 30% of ganglion cell loss occurs before the white and white perimetry picks up the defect. So imaging has definite role in picking up the early disease. And I'll just give one example. You can see the classic is a vase shape defect superiorly, inferiorly. It is more highlighted in the red-free photograph. And the white and white perimetry has just showing little bit of nasal step and blue and alloy also. So the perimetry usually takes little time in, at least in early stage, and has lots of taste retest variability. So imaging plays definite role in the early management, in early picking up the disease. Now, there are various imaging. I'm not going to talk about much because nowadays the optical coherence tomography and that to be spectral domain is the imaging technologies most of the ophthalmologists use. So I'll concentrate more on that only. I'll just give the logic. So, when the perimetry started and we are using perimetry for decades, so we have a normal range. We have developed normal range for each point, and sensitivity for each point is determined. The range is arbitrary, and basically it includes the normal population. The lower 5% of the normal population is what we usually said is the abnormal 5% defect level. Then we use the 2% as a 2% and less than 0.5%. So we use the normal range to decide the abnormality. So we have to understand that every abnormal doesn't mean it's a disease. It is basically the chance, the probability of that particular patient of having disease. And the same thing, the imaging and the perimetry, they have a similar thing. We have developed the normative database, and based on normative database, we decide the abnormality value. So here we go by the percentage. We have in imaging usually percentile. We have upper 95 percentile, lower 5 percentile, and lower 1 percentile. The lower 5 percentile usually is borderline, lower 1 percentile is abnormal. So basically the same principle that the normal range is developed, the range is arbitrary, and everything what machine labels abnormal doesn't translate into disease. We have to correlate clinically. That is the most important point we have to keep in mind. Now I just go briefly about how to read printout, though everybody is using it. What I do, like in perimetry, we have 8 zones. I divide OCT into 4 zones. The first one is the upper one where the demography is given. The name, date of birth. Date of birth is very important because if the technician is enter the wrong date, then the machine will use the wrong age group for the comparison, and there would be a problem. So you have to see the date of birth, the scan, the quality of scan, because if the quality of scan is 6 or more, then you are sure that it's most probably a robust data. If the scan quality is poor, which sometimes can be, then there would be a problem in analysis. And usually I don't like to use this data in management if it's less than 5. Look for the artifacts. There are various artifacts. Can be because of the patient, can be because of the technician, can be because of the media opacity. So look for the artifacts. I'm not going to go in details because artifact itself is a huge separate presentation. But you have to look for the different artifacts which can develop during the scanning. The zone 2 is the data which machine has obtained. the thickness map. The thickness map, you have to remember, the darker the color, the normal the value. If it's a red or dark yellow, the values are normal. If it is blue, light blue, then RNFL is thin. So this is what is the gross value. Then the third zone is here. That is the deviation plot. So this is a superpixel analysis where the magnitude of RNFL defect is analyzed. And here the darker the color is, the more abnormal the value. So the red would usually point out to P less than 1 percentile. The yellow is 5 percentile. So this is zone 3. And the zone 4 is all other data where you have the XY graph of neuroretinal rim thickness, RNFL thickness, you have a quadrant wise analysis of RNFL, and you have each clock hour. And there is a table about the disc area, rim area, and average RNFL thickness. So this is the zone 4. Each zone is important. This here the RNFL important. It gives you the comparison with the right and left eye. The dotted is left. The darker is the plane is right eye. So you can compare the RNFL value between both eyes at what is happening, and if retinal rim and retinal RNFL thickness. So it is a graphic representation. This is the quadrant wise. Again, the same thing. It divides into superior inferior quadrant, which are more important compared to nasal temporal, and you each clock hour. Again, the superior inferior clock hours like 5, 6, 7, and 11, 12, and 1 is more important than the clock hour which comes in temporal and nasal area. And I'll just give one. This is from the status times domain, but it very nicely elaborate that you have a right eye, you have a left eye where there is RNFL thinning, and it gives a comparison. Then you can see very nicely that the left eye RNFL is thin both superior and inferior, which is the area you are more interested in glaucoma. You can see right, left, and the comparison. The superior, the right has maintained both double hump pattern, where the left double hump pattern is lost, and there's a significant RNFL thinning. So this is how you can see the OCT interpretation. This is the table. The table, usually I don't pay much attention, but you get a fair idea about the disc area. And you can see this disc area is 1.8, which is on the little bit on the smaller side. The gray is something where the machine tells you that there is no normative database for the comparison. The yellow you know, the red you know, the green we know, and this is one gray, which means that the machine doesn't have enough normative database to compare, do statistical analysis. Now the World Glaucoma Association consensus is very clear. It says that there no single examination method alone is adequate for the diagnosis of glaucoma. It is recommended as a clinical tool to augment and facilitate the assessment of optic disc and RNFL in management of glaucoma. So the bottom line is it should not be used in isolation, which is habit sometime in general practice. They do only OCT and see that OCT shows red color, so is abnormal, green is normal. No, you have to do a proper clinical examination and then use OCT along with your clinical examination to augment your diagnosis, not in isolation as a screening tool. And in fact, the World Glaucoma Association, it goes down and says that optic disc imaging is useful in expert's hand in only in certain cases. So please be careful using OCT in isolation for the diagnosis or to rule in or rule out disease. It is going to be a counterproductive. It has to along with a proper clinical examination. Now the second, because glaucoma is a chronic progressive neuropathy, the diagnosing progression is very important. So if you look at the definition of progression, it says that evolution from disease from one stage to another stage. That is, if you have a detectable nerve fiber layer changes to increase in the nerve fiber layer changes, or if there is a no nerve fiber changes happening beginning of the nerve fiber layer changes, you can see on OCT there also is progression. So I am not going to talk about that when to treat progression. I am just going to talk about what is progression and how we diagnose on imaging technologies. But this is the various steps described by the Professor Van Rep long time back in 2004. So there are two: visual field progression. Ronnie has already talked. Again, we will have discussion about structure function correlation. So I will talk about the optic disc, and I'm going to concern only on imaging. So I'll just give one example. That visual field is gold standard, and I'm not denying at all that the progression on visual field is more robust and more important from day-to-day clinical practice. But sometimes the patient do find difficult to do perimetry. And this is just one example I'm showing. We can see that this disc is not looking that bad. The patient is just not learning how to do the field. So it shows the visual field, advanced visual field effect, both superior, the nasal step, and it looks classic. But if you look OCT all the time, this is from my spectral domain data, whereas status time domain, it's stable. And this is in between. I had to monitor, I had to explain the patient, not technician. I gave the time and he could do better. But every time is not possible for us to do the perimetry, guiding the patient in all the patients. So some patient, and if you look the data, at least 8 to 10% of the patient do not learn how to do perimetry despite repeated training from the experts. So for those patients, imaging may be a better way of managing, though I'm not saying in every patient. Imaging has its own limitation, but in few patients. So how to diagnose progression on OCT? So there are event-based analysis, just like the perimetry, and we have trend-based analysis. So event-based analysis uses the two baseline, and from third baseline, you can start picking up the progression is the advantage. But there is a variability, the measurement error is involved, so event-based analysis do have a problem. And it uses only few limited field, not all the database. So there's a problem with event-based, but yes, event-based usually picks up the progression much earlier than trend-based analysis. So that's a advantage of event-based analysis. The limitation is it's susceptible to outliers and may identify false progression. So if you combine both event and trend, it's always better. Now trend, on other hand, usually require at least 5 to 6 field or imaging to make a slope. So once you have 5 or 6, the trend usually is much more stronger and picks up even a smaller changes. So that's the advantage of regression trend-based analysis. And you can have a trend-based analysis where various we have in OCT. I'll just talk about it. And it also has the advantage of trend is the regression slope also gives you the idea about the rate of progression, which the event-based analysis is not able to show. So that's the advantage of rate of progression, which is very important in glaucoma, which your regression analysis will give. So that's a trend. It's susceptible, less susceptible to fluctuation. That's the advantage. But the problem is that once you have 6, 7 field, and if you make the slope, subsequently the slope will remain the same downhill. So even if your disease is stabilized after that, it will continue to show the one downward slope. So for these, there's a limitation of trend that you have to make a new baseline and look for the progression. So you cannot use the old data in the trend because the slope would be downward. So this is how the OCT progression printout looks. This is two baseline. This is the two subsequent field. So this is the event-based analysis. This is trend-based analysis. And this is how it gives you. The yellow is possible loss. The maroon red is likely loss. And the purple is possible increase, which usually doesn't happen in glaucoma. So you know that this is because sometimes if your earlier imaging technology had the low quality value or subsequently low quality value, you can have these kind of thing, but this is practically not important because RNFL or ganglion cell is not going to increase over a period of year with current management. So this is event-based analysis. The progression map, this is two baseline, two follow-up, and this is how it marks. I'll just come into detail. Then other is the RNFL thickness profile progression. It divides the whole area into 64 sector. And if the 4 sector shows progression, then it will mark as a progression. That is the thickness profile progression. And this is various trend-based analysis, the average RNFL, superior, inferior RNFL, and cup-disc ratio. So first is event-based analysis. Basically, it uses minimum the 2% of image area. So even a small progression can be picked up by event-based analysis because it is a super pixel, 150 pixel is used, only 2%. So even if the changes is in 2% area, the machine can pick up progression. That's the advantage of the this analysis, event-based. The second, I already mentioned the profile progression. It is divided into 64 sectors. If the 4 sectors shows worsening, it marks as a progression. And here you can see in OCT. So this area shows thinning 4 sector. It is marked as progression. This both is designed for the 95% specificity. And third is the trend based. We have average, superior, inferior, and cup-disc ratio. And this is how the line is marked. And if one point, This you can see this mark is yellow. This is gone into red. So it also shows the whether it's possible progression or likely progression. So all put together, this is the three way the OCT picks up, the RNFL analysis picks up the progression. And it also gives the value for each visits. So you know that what is the happening to the row of RNFL value, and what is the difference, how much is gone down. The GCC also the same thing. You have event-based analysis and you have trend-based analysis. So basically the same thing. If possible is yellow, the red is likely. So these are the two RNFL and GCC progression which we can look into the spectral domain OCT. And this is how just one example where you have a perimetry, you have a GCC and you have RNFL, and this area is marked progression. It correlates here and on the perimetry. So this is how of course the forum will be discussed in great detail, but I just given one example. So the most important thing is that you have two baseline which you should do in the as smaller visits as possible. You also should look at the variability. If your quality is not good and if the variability is too high at baseline, then your subsequent analysis would be a problem. You can see here the value is 72, 64 is gone down. So these two variability itself would make your subsequent progression analysis less robust. Now, which parameters is most important? I usually rely more on RNFL. Of course, GCC also is important. The most important thing is if you look at the advanced imaging glaucoma study, this is the focal loss. Both in GCC and RNFL is important. And now there are certain studies, they have come up with the glaucoma composite progression index, which uses both structure and function. So that would be one more parameter in our armamentarium to look the progression, though it's not available commercially at this point in time. So what I do, I look the whole printout. Of course, I have a full clinical picture in my mind. Do entire scan, look completely. Don't go only by the red or yellow color, because then you are bound to make this red disease and green disease. So you correlate and look whether the area which you have done in mind, like if a patient had inferior thinning and now converted to inferior notch, the similar area on OCT should show progression, not somewhere else. So you should correlate your clinical finding. So look for the focal changes, not only average changes, because usually the glaucoma changes would happen focally. So three ways the damage can happen: the new RNFL defect, you can have widening of the defect, and deepening of the defect. So these three ways you look and the forum of course will help you in certain way looking for the progression, and you also will tell you structure function correlation also. So I am not going to go in detail. I just show a few slides. This is how you have a VFI, average RNFL thickness. This is your event-based analysis and your RNFL, and it correlates here. You can see that GPS progress and inferior RNFL thinning. This is a perfect correlation of structure function progression. You get a fair idea. So this is one of my real patients. You can see that GPS worsened. Patient has developed inferior RNFL defect, is widened, and has GCC also is widened. So the patient has progressed. So this is how you can look for the structure function correlation. These are some of the example. I'll just go briefly. The NTA segment module also is there, which we can use for the angle closure glaucoma. We can look the scleral spur, Skems canal. Basically, you can measure the various parameters like AOD 500, AOD 750, and this can use for the angle closure. I mainly use the ASOCT is to look for the lens vault, which is very helpful in certain patients of angle closure. So this is how and second thing, to show patient your angle is narrow. So sometimes, when you do the gonioscopy, patient is not convinced. If you take and you can show that your angle is narrowed down compared to normal population. So for teaching and the lens vault for my angle closure management. And this is from the TNONGS data that the lens vault is definitely more in angle closure patient compared to the normal population. And it helps in certain patients in deciding, not in every patient, but certain patient, where if I want to do the early cataract surgery, I use the lens vault as my one of the parameters to decide the surgery. So to conclude, the clinical diagnosis is important. Imaging helps for the diagnosis, early diagnosis. It helps for the progression, but it has to along with your complete clinical picture, and you have to look the disc carefully and the imaging. The OCT will help you picking up the disease as well as progression. Thank you.
Thank you, Dr. Rajul, for bringing in clarity in terms of the role of OCT in diagnosis of glaucoma. Any comment or any question from any of the panelists?
Yeah, I think that was a wonderful talk, Dr. Rajul. And the parameters we have assessed, like you said, the AOD 500, AOD 750, and the TISA. Which one of these parameters do you think have more sensitivity in diagnosis of angle closure disease?
So, Dr. Balla, I don't very frankly, I don't think that ASOCT is important to the diagnosis of angle closure. Gonioscopy is more important. Gonioscopy is more important. I very frankly, I use to show that I may do the measurement and show them that your angle normal usually is more than 30 degree. In your eye, it shows 18 degree, 20 degree. That is what I use. AOD, I calculate from the study point of view, but I personally don't think that they have much value in diagnosing angle closure glaucoma. Ronnie can have his input.
I agree absolutely. I don't think the ASOCT should be used to make any clinical decisions regarding angle closure glaucoma beyond explaining to a patient or assessing what the lens work is.
So I think very rightly stressed upon is that the gonioscopy is the gold standard, and these aids, these diagnostic modalities just help us and aid in strengthening our resolve whether to do peripheral iridectomy or not. And we can also show the patient that this is what his angle looks like, and the PI will be helpful. I think is that okay, sir?
Absolutely, Dr. Balla.
Right.
I just want to ask one thing from Dr. Raju. Can we use OCT to differentiate between physiological cupping and case of glaucoma? Suppose somebody comes to you with a normal intraocular pressure, but a very, say, 0.6 cup, deep cup. You do visual fields, one or two areas, one or two spots of low sensitivity, and you are in two minds whether it's physiological cup or it's a very early glaucoma. So and the corneal thickness, etc., are all within normal range. So can OCT help in that?
So of course I do imaging. If the disc looks suspicious, that's the first bottom line. So if I'm convinced that inferior rim is thicker than the superior rim, and my suspicion of the glaucoma is very low, then the role of imaging is limited. But yeah, if I have doubt inferior rim is equal or thinner than thin, then I do OCT. The only thing we have to keep in mind that only OCT should not be the criteria to diagnose glaucoma, which usually happens in not in India, it's across the world. People, that's why we say green disease and red disease. That people miss glaucoma because they, OCT would be absolutely normal, and they would start treating glaucoma because OCT would show some red, random things. So if the inferior rim is thin and OCT shows the inferior RNFL thinning, then yes, I would be, and I would think that yeah, it's possible. But eventually at the end of the day, to treat or not would be based on multiple other parameters, not only OCT. So if the pressures are only 20/21, if there is no family history, and if let's assume that patient is old, 70-75, then I would definitely wait. If patient is young, then also I would wait. I will call back. I'll do multiple pressures and see whether pressure is high fluctuation or not, whether the multiple risk factor justifies my treatment. Otherwise, based on only OCT, I would not treat the patient.
Thank you.
There's a question.
Yeah, Dr. Ajit wants to say something.
Yeah, if we have come across a patient like what Dr. Sinha suggested, would it be a good idea, you feel, that we get the baseline OCT done, because this may be one point in the spectrum of disease over the patient's lifetime? So for future comparison.
Baseline imaging, baseline perimetry, both are fine.
Yeah,
absolutely.
And subsequent follow-up, the same can be done for us to see whether there's any progression at all or not.
Yes.
Yeah, Dr. Namrata was asking some question. Ma'am? Okay. Dr. Bhalla?
Yeah. No, I think there are no more questions on that. It was very nicely presented by Dr. Rajesh Parikh, as always.
Okay, so we move on to the next talk. And
so, Dr. Bhalla.
sorry.
Yeah, I'll invite the next.
Yeah, I'm just sharing this slide.
Meanwhile, there is a question for Dr. Ronnie George. Will there be any change in applying Anderson's criteria to 24 to see faster since it has additional points?
No, there would be no difference to the way it is graded, yes.
Yeah, Dr. Bhalla.
So I'll invite the next speaker, Dr. Ajit Hazari, and he's going to talk on Forum Glaucoma Workplace, improving clinical decision making and workflow using integrated diagnostics. Dr. Ajit Hazari has done his fellowship in comprehensive ophthalmology from LVPI Hyderabad in 2001. His clinic, Hazari Nursing Home in Aurangabad, is a major tertiary referral center for treatment as well as surgery for glaucoma in Marathwada region. He has also served as an adjunct faculty for LVPI Hyderabad and has published numerous papers on cataract surgery and uveitis in Indian Journal of Ophthalmology. He's given more than 100 lectures, workshops, and live surgery sessions in the field of glaucoma, cataract, premium IOLs, and toric IOLs in Maharashtra and at national level. And Dr. Hazari is also a trained instructor for iExcel and iLead corporate programs of the Art of Living Excellence at Workplace. Dr. Hazari, sir, stage is all yours.
Thank you. Yes, thank you for inviting me for today's talk. I'll be speaking on integrated diagnostics and how it helps in decision making and workflow using the Forum Glaucoma Workplace. So, I have no financial interest in the products or softwares that I'm be talking about in this presentation. We know that the parameters to monitor glaucoma include disc evaluation, IOP monitoring, perimetry, and OCT. A good disc photograph is a good way to document the disc appearance, especially when you have more than one physician caring for the patient. And having access to photographs quickly helps in assessing changes that happen over time. Similarly, with IOP charting, if we are able to map the IOP over a period of time, it is useful to get a quick look at the overall trend for the patient, and we can pick up that the IOP, if it's been increasing gradually over a period of time recently or so. Similarly, when we are looking at OCT, now we need to realize that we can't look at only the RNFL, we have to equally consider the ganglion cell layer analysis. And when we combine both these together, we get more useful information. So sometimes RNFL defects, which may be confusing, but when they correlate with the GCA thinning, it significantly increases the sensitivity and the specificity for diagnosing glaucoma. Combining structure and function in our evaluation improves the sensitivity and efficacy while monitoring glaucoma changes. So we'll be going in more detail about this at a later part. But if we are looking at progression of our patients, and if we are looking at individually perimetry or OCT, then we see that only 4 to 5% of the eyes will show correlation and progression in both the devices at the same time. So why does this happen? Well, the reason is that in early glaucoma, we have a redundancy of the retinal ganglion cell layer. So as a result, the visual field does not get affected initially, but the OCT, a well-done OCT, will pick up defects earlier in these early glaucoma patients. Similarly, in advanced glaucoma, the OCT will have a floor effect due to the severe RNFL and the GCA loss, But if we do a properly done perimetry, we'll be able to pick up progression. And in these late stages of glaucoma, we may come across fast progression, which can be seen on perimetry, and especially the central fields like the 10-2.
It is not 4 publication, it is 64 publication.
If we look at the structure function correlation,
if it's 4, then I would not have mentioned. 4 is peanut. It's 64.
There's a redundancy of retinal ganglion cells in the initial stages of glaucoma, because of which the perimetry does not show any defect, but the RNFL can pick up early defects. As the damage increases in moderate glaucoma, the visual field as well as the RNFL as well as the OCT both can pick up the defect, while in late stages, the visual field is the one which deteriorates, which goes downhill, and the RNFL will not show any changes because of the floor effect. So the algorithm that we follow in our clinic has been suggested by Dr. Greenfield. And in early glaucoma, we rely more on the photograph and the documentation of the disc images, the imaging from the OCT, and less so on the visual field. But that is also changing with the 24-2C CETA faster. In moderate glaucoma, we depend more on imaging and the visual field. And in severe glaucoma, we rely more on the central visual fields, that the 10-2 test specifically. So coming to today, the main part of today's talk, which is the Glaucoma Workplace, what it does is that it integrates the data from the perimeter, the fundus camera, and the Cirrus OCT and the OCT together in a single software, and we can see the results on the single computer screen. So if we look at what Glaucoma Workplace does, is it does broadly 3 categories of functions. One is archiving, where it archives the reports from the perimeter, the OCT, and the fundus camera, and probably in the near future also the OCT angiography. And because it saves all the raw data from all these devices, it is capable of creating reports remotely for the perimeter as well as the OCT and the structure function analysis. The most important part, I feel, or the most useful part of the Glaucoma Workplace is real-time custom analysis of the raw data. And with this, we can generate the glaucoma progression analysis from the perimeter data, from the OCT data, as well as the structure function analysis, where we combine the perimeter and the OCT data. So we'll go over a short video in which I'll show you typically how I go through Glaucoma Workplace screen when I'm evaluating my patients. So this is the starting screen where you have the patient's name here and all the tests that have been done for that patient once, and it's very intuitive. So you just double click on it and it opens up the screen. So this is today's visit, for example, the current visit, which is seen here, March 9, 22. And you see all the reports that are present from today's visit. Here you can look at individual reports from the individual devices. For example, this is the RNFL printout. You can also get the progression analysis printout, the GCA progression analysis, also the ONH angiography, then for the other eye. So serially, you can keep looking at these reports. You can also pick up the fundus images and look at them more carefully to see if there any changes have happened. For example, this patient has come 2 years later after the lockdown, and we've seen that there's a new RNFL defect which has happened in the right eye, and so forth. Similarly, what we can also look at the reports like the structure function analysis combined report, where we look at the perimetry, the disc photographs, the ganglion cell layer analysis, and the RNFL all on the single page, and the subsequent pages have detailed analysis of that report. Similarly, we can look at individual perimetry reports. We can draw up multiple reports at the same time on a single screen, and then look at each one of them in more detail. So here I've selected 4 or 5 reports at one time, and then I go to the document display button, and then I have all these reports right in front of me on the screen. So I don't have to go through the patient's file over and over again, look at the various reports individually. So here I can flip through individual reports as they come up on the screen in front of me. And as Dr. Ronnie said, with the Glaucoma Workplace, you can integrate the 24-2C and the previous 24-2 seamlessly. So there's no loss of data, and we can easily look at all the data within no time. Similarly, what we can do is we can select a particular device. For example, here I'm picking up the disc photographs over the last few visits of the patient, going back to 2018, 2016, 2015, and pull all of them up on the screen and look at each one of them individually. And if you look at the first visit, first picture and the last picture, we see that there is a new RNFL defect which has happened. So this makes it so much faster, and there is no loss of data. There's no question of loss of patient's file or papers, or your previous drawings which you've drawn on the paper have got lost or got smudged. So all those factors get ruled out completely. Then another good feature is we have all the tests of the patients on the screen, and we can pick up any particular test and look at it in real time. For example, we have the 24-2C or the 10-2, and we can just select it and see it individually if we wish. Similarly, there's another button for looking at the overview. Now, if we look at the same patient starting from 2012, where his right field was almost normal, subsequent fields were also normal for the right eye. And then on the overview printout, we start seeing that the inferior field has started showing a few depressed points. And then he gets lost due to lockdown for 2 years, comes back with the enlarged inferior arc with scotoma, and which has progressed further in the last 1.5 to 2 years. Similarly, we can look at the 10-2 also. And so the convenience of the Glaucoma Workplace is that you don't have to sift through multiple papers from the patient's file, and you get everything on the screen. Coming to the most important, or the most useful part rather, I'll say, of Glaucoma Workplace is the structure function analysis. And here we can pull up data automatically from the perimeter as well as the OCT, and that all that data is shown in front of you on the screen. So here we have the mean deviation on the upper left corner, and we can also look at what part of the field we want to see. Let's say if the field was mostly damaged inferiorly, we can look at the inferior mean deviation, or we can look at the superior mean deviation or the overall mean deviation and see whether the rate of progression is changing. And in this case, the rate of progression was increasing for the inferior field. Similarly, for the visual field index, we can, and it's so customizable that you can change the buttons anywhere. You can pick any data in any part of the screen so that it becomes more streamlined. On the right-hand side, you have the OCT data. You have the average RNFL thickness, average GCL IPL thickness. And for the GCL IPL thickness or the RNFL thickness, again, you can look at different parts. You can look at the upper half or the lower half of the RNFL. And that can give you a better clue as to what part of the field is deteriorating and what we clinically feel that there is progression or deterioration. Is it panning out in the OCT imaging and the perimetry testing? So similarly, for the ganglion cell layer also, you can decide whether you want the upper half, lower half. Then you can scroll down to the perimetry, and you have the progression analysis, and the event-based analysis shows that there is possible progression. And at the same time, you can look at the actual pattern deviation plots or even the grayscale. Here I find that sometimes the grayscale, if I show to the patients, it's easier for them to understand that over a period of time, the grayscale is showing some changes. And you also have an option of looking at tabular data. So individual fields, you have all the data which is important from the perimetry gets picked up on the screen, and you can look at individual data from the perimetry. Similarly, for the OCT data, you have the deviation map, which can show a progressive changes or increase in the RNFL thinning. Then you have the color-coded maps also, which shows the thickness map for the RNFL, the GCA. And we can also look at the tabular data or the actual numerical data of various quadrants to see where the progression is there. And at the bottom, you have the disk photographs, and you can click on them and evaluate them further. So in this way, you have a lot of flexibility according to how you want to analyze the data, and multiple forms of analysis are available to us very easily, and it hardly takes any time. So here, for example, this is a 8-minute clip that I've done with screen recording, and in these 8 minutes, I've looked at 10 years of the patient's data. Another useful thing which I've seen is the progression summary which comes, and that shows that the machine automatically analyzes the various parameters for progression, and you can click on either of the eyes and it expands into the structure function analysis for the patient like we've done just now. So here you can also evaluate the cup disc ratio and other parameters. So there is a lot of customization available, and I feel that it's a fantastic tool to use. So in my clinic, what are the advantages that I've come across with after using Glaucoma Workplace for the last 8-10 years that I've used it since 2013. One is that what I've acutely become aware of it is in the last 2 years, I don't have to sit in front of the patient and analyze all his reports. I can sit in my chamber, look at it on a remote terminal, look at all the reports at a remote terminal, go through it in all details. So I'm completely armed with all the data for the patient. And when I go in the examination room to sit in front of the patient, I can quickly explain everything to them. So detailed analysis of the reports is available remotely. So we are better prepared when we see the patient in the exam room. As a result, what happens is that we save a lot of chair time, and it also improves the quality of chair time. So this results in better communication with the patient. And as a result, the patient's self-confidence improves, patient's understanding of his condition improves. This results directly into better adherence and compliance to therapy. And the added advantage is that the graphic presentation on the screen is very intuitive and has an easy layout with very simple graphs. So this is very easy for the patient to understand. So to summarize, the advantages of Glaucoma Workplace are in archiving. We have all test data available, which can be accessed anytime, anywhere, through cloud or through remote access through a LAN cable also. And of course, there is no risk of data loss. Reports can be generated anytime without accessing the individual machines, as the software from all the machines gets stored on the forum software and we can analyze it there. The real-time analysis of data gives us the capability to do custom analysis and reports, example, the upper or the lower hemifield data from the perimeter or the OCT. And real-time study of the glaucoma progression analysis, not only for the perimeter and the OCT, but also their correlation to study the structure, function, progression. And I wasn't able to pull up the report of the structure function GPA in the video, but you can get a special report which talks about the structure function progression, and we can give that to the patient. So the Zeiss Glaucoma Workplace is an invaluable asset to glaucoma practice, as it adds value to the better management of glaucoma for the patient as well as the physician. And I can vouch for it because we've been using it since 2013, and it has become an integral part of our management process. Thank you.
That was really fantastic. Very, very nice presentation. Any comment from any of the speakers, panelists? Dr. Balla? So I was just feeling that, how often do glaucoma specialists feel the need of this kind of a workstation? And you showed very well how, the progression can be, seen and all those things. So the idea was that how often do you need such a workstation?
Right. So I think that's a brilliant question. And I'll tell you from my experience that when in the early days, I wasn't using Glaucoma Workplace so often. And when I had to make a case presentation or prepare for a talk, and I would pick up cases from my practice and look at all their data, and when I'm looking at it carefully at all those data, I realize that I've missed this damage which happened 2 years ago, 1 year ago, 3 years ago, and I wasn't looking at the pressure, or I wasn't looking at the correlating early defects which were getting picked up on the ganglion cell layer analysis or even the RNFL. And that's when I realized that I have to make a habit of looking at this data systematically, because when we're sitting in front of the patient, and if we are looking at only at that day's reports from the patient, it's very, very easy to miss subtle changes that may happen. For example, today's patient that I showed in the video, he came after almost 1.5 years. And when I look back at the Glaucoma Workplace analysis, and then we had already picked up defects on his RNFL as well as ganglion cell layer 1.5 years ago, and I had warned him about it, that we need to look at it more closely. But unfortunately, he was stuck in Delhi. He couldn't come back to Aurangabad for 1.5 years. And then today, when we looked at it, and incidentally, that patient is also an ophthalmologist, though a retired senior person. But and so this is where it really makes a difference, where you want to really fine-tune the management of glaucoma for the patient. You have to look at the small details. You can't just look at red, green, and so on and so forth, what Raju warned us against. We have to look at the individual data points. And that's where the Glaucoma Workplace, I feel, is invaluable.
Yeah, Dr. Ronnie, yeah, please.
Yeah, so we have actually networked the instruments all across the system. So I can actually even seamlessly look at a visual field that has been done in Calcutta. In our branch in Calcutta, I can see what happened to the patient from here itself. And we have the software on all our glaucoma OPD, in all our glaucoma OPD. So every patient, literally, I have the EMR open on one side and I open it up, and whenever they've done an investigation, I open this up and look for progression. The other advantage is I can decide which field I want to take out, which point I want to look at. It's really, really helpful in daily practice. Once you start using it, you wonder how you manage without it.
Yeah,
I totally agree.
Yeah. And so, sometimes if you just look the slope, the average, VFI or something, then it may be look stable. But then if you look that patient, inferior, superior, and you can make out that, that particular area is really worsened and the slope would have been significantly negative. So you can look out the specific progression, the specific area that Ronnie was mentioning. That is the big plus, because otherwise, other than forum, you cannot look for that localized progression.
Another advantage that you have is you can actually even look at serial 10-2s.
Yes.
It will give you a trend analysis for that, which is not available in any other form.
You can, yeah.
So it's again a very good tool for having publications and present your papers, present your cases, no? Because you get a systematic data in that.
Yeah. And management, because as Ronnie mentioned that, mentioned that the trend bet on 10-2 is only possible. You can look forum, and also you can look the average MD value. You can look the superior, inferior. So you get a fair idea that if the patient is only worsening in superior and average is not showing the significant progression. If you look only superior MD slope, and you can make out that patient has a significant MD slope, and you may want to investigate or manage in a different way. So, it's a very good tool.
Yeah. And just wanted to add one thing that, by mistake in the slide, it was written 4 publications for Dr. Rajul. Actually, Dr. Rajul has done many more than that. He has done 64 publications in peer-reviewed journals. So just wanted to correct that. Yeah, let's continue our discussion. So you think that it is a tool which one can think of acquiring if somebody is having a well established, or someone wants to establish a glaucoma practice, right?
Yeah, it becomes a need of the day as you keep looking at glaucoma patients over a long period of time. I think we owe it to the patients that we need to look at the data more carefully.
Okay. There's one question that has come up for Dr. Ronnie, and the question states that is it possible that that faster you go, you can have some mistakes? So in Sita Faster, can we make some mistakes, and can the sensitivity of the field by Sita Faster may not be as good as standard?
That's not strictly true, but there are 2 reasons for it. One is, we have to remember that the principles of visual field testing don't change. You still have to pay attention. You still have to fixate centrally. You still have to respond only when you see something. So if somebody is trigger happy and goes trying to finish the test as soon as possible, then it's possible that they're going to miss it. But on the plus side, you have to pay attention for only 2.5 minutes instead of 6 minutes. So you're less likely to have fatigue-based errors.
There's one more question for Dr. Rajul, actually, that apart from, if somebody has a comprehensive practice, then do we really need to have an OCT for analysis of retinal nerve fiber layer, or visual field subtle changes can be sensitive enough?
So I don't know from where. See, if you look now, I'll just answer differently. I think OCT machines are there. Even most of the comprehensive general ophthalmology is the OCT machine. So these questions has become more of theory, because there are rampant everywhere. At least in Mumbai, I think every 5th or 4th ophthalmologist would have OCT machine. But having said that, I think a good clinical examination and perimetry, if you really do not have OCT, it's not that you cannot manage glaucoma. It's not like that. A good clinical examination and perimetry would take care of your majority of the patient. The imaging helps in addition to the perimetry. So if you use structure and function both together, you are likely to able to manage patients in a better way. It's not that you cannot manage without imaging. Yeah, but if you said that I don't want to, you do perimetry also, and I want to do only clinical examination, then yeah, you are bound to make mistakes. So good clinical examination, which includes appellation tonometry, and I'll say, because lots of general ophthalmologists in Mumbai, I see they use NCT. So that is not the way to manage glaucoma. So a good comprehensive examination, IOP, gonioscopy, and perimetry would take care majority of the patient. The small number of patients do require imaging on a routine basis. I do imaging in all my patients. But then I'm a glaucoma specialist, and I collect data for presentation, publication. So it's a different thing. Yeah, you don't require OCT for every patient to do a good examination, but it helps.
Thank you. Any other question, ma'am?
I don't think there are any other questions. Some of them, I think, have already been answered.
Yeah.
How to correctly read a Humphrey visual field chart, I think was not in the purview of this webinar today. And will we, this have already asked, will we have any change in applying Anderson's criteria? So that is there. And some of them are very general, like what is the new criteria of diagnosis of glaucoma? So I don't know. I mean, there must be so many new things. So I think the others are more or less general. Some questions are there about therapy also. So I think there are no more questions. Anybody would like to make any comment or?
Actually, what I felt was that all the three talks had complete clarity as far as the substance of the talk is concerned. So that was really very useful for all of us, for people like us also who are not non-glaucoma cornea specialists. So we learned a lot. And of course, there are many people who are watching who have sent questions. They are also appreciating. Also, there are a lot of words of appreciation also, which I think we should mention now, because till now we were just asking questions to other speakers. So it was a wonderful session, and we all thoroughly enjoyed and learned a lot. So any comment from any of you, Dr. Ajit, Dr. Ronnie, Rajul?
I think what this highlighted is that glaucoma is not only about diagnosis, it's about detecting progression and doing that as well as possible. And I think that is the crux of the entire thing. It's easy to diagnose glaucoma, it's difficult to detect progression.
So thank you so much for this webinar. Thank you for your time, for your contributions. And I always feel glaucoma is a very difficult specialty, because I see in our glaucoma clinics, once a patient is, I think, always a patient lifelong and for many years to come. So the patients never leave you, unlike other specialties where the patient leave you at some point in time. And again, thank you very much for your time and for your contribution. And I would also like to thank Dr. Rajesh, Dr. Bhalla for being here, and Zeiss for putting this all together and doing this scientific deliberation on the platform of All India Ophthalmological Society. And we would also like to thank our audiovisual team and the people at AIO's headquarters, Mr. Kripal, Mr. Sharik, and Dr. Anand Sethi and his team from the audiovisual department. So thank you so much.
I would just like to add one more thing, is that glaucoma is a very popular specialty as well, because what we have felt that the attendance is always very high.
I really don't know, maybe it's higher than when we do cataract surgery webinars.
Yeah. So I guess glaucoma is the most popular specialty, thanks to all of you glaucoma specialists.
Yeah,
popular.
We will always have very high attendance, whether it is YouTube or Facebook or Zoom portal. I really don't know the reason, but the numbers are always very high.
Yeah.
So thank you so much, and hope to have you again very soon. Dr. Ronnie, we are having almost daily. I'm sure you all must be very busy with your.
Yeah, this glaucoma week, you must be very busy, no? Every day.
You must be talking not once, but maybe more than once. So thank you.
Thank you, ma'am.
Thanks, ma'am.
Thank you,
Rajesh.